Thank you. Good morning and welcome to the Alzheimer's Disease and Related Dementias Task Force meeting. At this time, I'll turn it over to Alex Lapso to call the roll.
Thank you, Director. As I have in the past, I will begin with calling the names of task force leadership, proceed through governor's appointments, our legislative appointments, and concluding with representatives from our executive agencies. Chair McElroy is here. Vice Chair Dieferheimer?
Yes, I'm here.
Thank you. I'll now begin with governor's appointments in alphabetical order, beginning with Addison.
I'm here.
Beach.
Here.
Blau. Bolin. Brockman.
Here.
Brode. Berman.
Present.
Drost. Hockwald.
Present.
Johnson. Pakunka.
Here.
Mahajan. Reese. Russell.
Here.
Schiffel is excused. Smith.
Here.
Stevick Rust.
Here.
Thompson.
Here.
Van Runkel. I'll again call the name Blau. Bolin.
Present.
Brode. Drost.
Present.
Mahajan. Reese. Van Runkel.
I'm here, Alex. I've raised my hand before, but.
Thank you. I'll now read the names of our legislative appointments, beginning with Leader Yuka.
Alex, I'm sorry. This is Pam Reese. I had you on mute.
Oh, thank you, Pam. Appreciate you letting me know. Leader Yuko, are you with us today? Senator Wilson?
Present.
Representative Creech? Representative House? I'll again call the name Leader Yuko. Representative Creech? Representative House? I'll now proceed to read the names of representatives from our executive agencies, beginning with Director Corcoran. Director Ashenhurst.
Here, thank you.
Ombudsman Laubert. I'll again read the name Director Corcoran. Ombudsman Laubert. Director, we do have a quorum.
Okay, we officially open our meeting. If you can, now everyone should have received, I believe, draft meeting minutes. Should have been attached to the meeting notice if they weren't sent out earlier.
Jean, I believe you do have some corrections to the minutes as drafted.
Yes, I do. Thank you, Alex. 2 items, bullet point 3. I believe in discussion, it was really all long-term options models had struggled during the pandemic to provide services because of decreases in revenue and funding due to the COVID-19 pandemic. Then also on bullet point 1, 2, 3, 4, 5, 6. Bullet point 9, the only reason I brought up that statement while it's true that most assisted livings are private pay, we do have a Medicaid waiver. And in the context I brought it up in the meeting, it was that we feel that would be would present a good possible option in terms of dementia care were it better reimbursed. I mean, I think I even quoted, which is the reimbursement at the highest level, $72.27 a day. So that's the only reason I brought up the other statement, is that the waiver would be more of an option were it funded better for memory care. Thank you.
Thank you, Jean. Are there any additional corrections or changes to the minutes?
Alex, just one minor. I did attend the last. I wasn't marked as present. I had joined late from coming from another meeting. So.
Understood. Understood. We'll go ahead and make that correction as well.
This is Debbie Ashenhurst. I was in and out of the meeting as well for other meetings, but not remarkably noteworthy.
Alex, this is Diane Pakunka. I don't believe I received the minutes, so I couldn't find them this morning again when I looked. So I'm just wondering, that should have come from Tessie with the meeting link, or where would it have come? Who would have sent me those?
Yes, they would have come from me, Tessie. It came in email, and then I this morning attached them to the meeting invitation as well. So let me double check that I have your email correct and that it's coming through. I might just send you one directly to see if I can have you add me to your address book.
I appreciate that. Thank you.
And Tessie, I didn't get any communications till early this morning. So if you could resend that stuff to me, I didn't even know we had a meeting until I was in my car at 8:45.
Okay. I'll double check that.
All right, thanks.
Well, thank you all for your input. Are there any other additional corrections or changes to the minutes as drafted?
Move approval as corrected.
I second that.
We have a motion from Pete Van Runkle to approve the minutes as corrected, a second from Jean Thompson. Do we have an objection to approving the minutes as corrected? Hearing none, the minutes will stand as approved.
Okay, so next up is my report, which I don't have much of a report today, except that I would just remind everyone that we are awaiting, as most people are, the main operating bill, our budget bill. I think that's why, I think I saw in the chat is why we don't have Leader Yuko here, I believe, as I did see that. And so there are some particular items of interest that we believe will be supportive of this work if in fact we're able to see them across the finish line. So we will have something much more to report in terms of status and where we are at our next meeting. So that really is my report today. I want to turn this over now to Sage Squirrel because I understand we have a lot to do. I saw the slides and it seems pretty significant. So I'm going to go ahead and turn it over to you, Lee.
Thank you, Director. Good morning, everyone. I hope you had an enjoyable weekend. For those on the phone, this is Lee Ann Kingsbury with Sage Squirrel. We do have a lot to do. I am doubtful we will actually get through everything, but we felt sort of better about being overambitious than being underambitious, if you will. So I'd like to. I'm sorry, did somebody ask a question? Okay, just wasn't sure if I was interrupting someone. Before I jump to the slides and start, I just would like to ask generally how you thought the process worked last week. And for folks who couldn't join us, let me just tell you really quickly what we did. We have some slides to share, but that's really more for information for all of you. This is not a slide deck presentation, if you will. We'll keep our questions up. We'll occasionally move to the actual topic just to make sure everybody is aligned with what the topic is and what the questions are aimed toward. We're using a bit of a round robin sort of process for answering questions, trying to ensure that everybody has an opportunity to share, and also to make sure that when we move from one topic to the next, that we aren't in a position where the same person starts every time and the same person has to go last every time. So kind of rotating that roster a bit. Just that's what we did last week. Let me just check with folks really quickly and see kind of how you thought that worked. Any changes that you'd like to make?
I see Doug, please.
Yeah, two things. First of all, I just want to kind of give a shout out to Jean about her discussion with the Alzheimer's or with the assisted living waiver. The assisted living waiver, of course, originates in the Ohio Department of Aging, and in my estimation, it's been underfunded now for about 10, 15 years. So anything we can do to help in that way with that waiver and help get more people with Alzheimer's in assisted living facilities makes sense to me. Coming back to your question, as I said last week, I thought that was the best meeting we've had. So if we can continue to move in that direction, I think we'll be able to wrap up when we're supposed to.
Okay.
All right.
Thank you, Doug. Anybody else? Okay, well, we will go ahead and dive in. I'll go ahead and share the slides just so you know kind of what we are starting with today. Give me just a moment here to pull these up. Okay, and can you see that slide? It should be just the header slide. Okay, great. Thanks, Christy. All right, so just a reminder of our general meeting agreements. We do our best to start and end on time. I will continue to be timekeeper. That seemed to be worked pretty well, particularly since my colleagues are actively taking notes and I don't have to focus on that. I will again try my best to respectfully and gently move us forward if we need to do that. If somebody is bleeding into somebody else's time, kind of moving into somebody else's time. I actually want to thank all of you. You all were so respectful last week and so kind when I had to do that occasionally. So thank you also for sort of joining me in that process. I really appreciate it. Quick reminder, mute your line if you're not speaking, or if you need to, grab your phone or turn around to talk to anybody in your office. And again, a reminder from my friend, misery is optional. We don't want you to be miserable. So please also take care of you as you need to. We will take a break in about the middle of this process, but if you need to break sooner than that, please feel free, do as you need to do, okay? We've done the roll call, we've gone through the minutes. Thank you, Director McElroy, for your welcome and your report. And I'm going to hand off to Yanda. I will admit we had a bit of a miscommunication. I did not send the actual findings because I thought our internal document was not complete, and I apologize for that. We had a bit of a scramble conversation this morning about that, and we have since figured out that process, and we will make sure that we get, it will be certainly a draft, but it will be complete and cleaned up and ready to go to you when I send everything to Tessie. And if there's other information you would like, I mean, right now, what I will plan to send each week to Tessie for distribution is a copy of the draft minutes, a copy of the draft findings, the agenda, and the slide deck that has the data we'll be responding to or using for that particular meeting. If there's anything else that you would like from meeting to meeting, please just let me know. I'm happy to put that together in the materials packet. So Yanda, can I hand it off to you for a brief review of what we talked about as findings for last week?
Well, absolutely. And I am I'm going to reveal just probably a little bit more process than we would normally want to, because honestly, for the group as a whole, we did draft, we all combined our notes, extracted what we felt were statements of findings that came out of Monday's discussion. But I needed to actually share those with the chair of the task force, and we have not done so. Unfortunately, there were a couple of emergencies, one minor, one perhaps not so minor, that impeded my ability to do that. So I do have a draft findings document, but it has not been reviewed and approved by Director McElroy. So Director McElroy, I would respectfully ask for your preference if you would prefer that I share this with you and you have an opportunity to review it before we share it with the group. And if we do it that way, then what we will do is be prepared next Monday to share where we are with findings through the whole process. But I did want to check with you first.
And that is preferred. And for the group understands, typically we meet every Friday. And as Yonda mentioned, there was an emergency and we couldn't do so. So I would ask that you hold on that piece and let's move forward.
We will hold on that then. Thank you.
Thank you so much for that clarification.
Mm-hmm.
All right. And so just a quick reminder of the buckets. I keep thinking there needs to be a better word than buckets, but for the moment we'll stick with buckets. For anyone who, again, did not join us last week, wasn't able to join us last week, we took SB 24 and kind of collapsed the 28 topics into themes. And for folks who are on the phone, we have a slide that's up right now. And those themes, just as a reminder, are early intervention, healthcare, long-term services and supports, safety and legal issues, policy evaluation, and then we have an overarching topic of equity, which will be woven through and we feel is embedded in all of those topics. Okay. We ended last week on the topic of, oops, let me go back one, sorry about that. Go forward, go forward, go forward. All right, let's do this a different way. There we go. So we ended last week starting to talk about safety and legal issues. We didn't really complete that conversation. We knew we were ending, and so we did kind of a quick conversation on that. So we've built in some time this morning to continue that, to see if there are additional thoughts, additional comments on that topic. We have about, excuse me, we're actually a few minutes ahead. I shouldn't even say that out loud, but we have about a half an hour for the continuation of this topic. So I'll open it up for that conversation. And again, as a reminder of the questions that we are talking about, we are asking kind of what is happening, kind of state of the state in Ohio in long-term services and supports relative to people impacted by Alzheimer's or other dementias. And just a quick recognition, I know most folks might be thinking, I can see the slide, I don't need to have it read. I want to make sure, I think we do have some folks who are on the phone, so I want to just make sure folks know what I'm showing. And kind of our focus of those questions is what's going well, what should we continue, what should we maintain, and then what areas do you see for improvement? And given what you know is working well, and given what you believe needs improvement, what conclusions and findings do you draw from that? And then we will look at the conclusions and findings we hear and kind of hold those up against the data that we currently have, examine explore whether we have data that supports those conclusions and findings. Do we by chance have data that conflicts with those conclusions or findings? And also, if we don't have existing data, where might we find it? So that's what we'll start today around the personal and public safety and legal issues. And my roster to start with. Director McElroy, let me just ask, do you want to contribute to this conversation, or are you a listening and observer today? Should I include you in my roster is my question.
When is she ever just a listener and observer?
That's a good one, Pete. I'm going to do my best to listen, but I may be led to, if that's okay with you, Leanne, to pop in from time to time. So
absolutely. Please feel
Okay.
free. I didn't want to leave you off the roster and didn't want to just assume that I should include you either way. So thank you.
Thank you.
All right. So I'm going to start with Diane, and I'm going to go Diane and then Tina and then Pam. So Diane, can we start with you?
Yes, I'm sorry. I got pulled away for a minute there. What's the, are we talking about legal issues, safety?
Yes. So we ended last week. We had kind of a quick kind of half of a conversation
Right.
about personal public safety and legal issues. So we've just carved out some time this morning to continue that conversation.
Right. Okay. And honestly, I had to leave before the end of the last meeting, so I did not hear most of that. The one thing that I would put forth here is actually the concern about training for first responders. Those individuals in police, fire, EMS, etc., who may have to deal with individuals who have Alzheimer's and dementia and various dementias, and how that training is being done in the state. Is the training similar from one organization to the next, and maintaining that and actually reinforcing that as much as possible. That's something that I've talked about with other members of AARP. So that's the one comment that I have about this.
Thank you, Diane. And I failed to mention, we have about 2 minutes per person. And Diane, you were absolutely fine. I just wanted to make mention of that. Tina, and then Pam, and then Jen Drost. Tina. Tina, are you on mute? Okay, I'll loop back around. I'm going to go ahead to Pam.
Can you hear me?
Yes.
All right. So I'm going to agree with Diane about the training for the first responders, but also I want to talk about the safety aspects of the individuals that are not only in long-term care, but also in the community. So many aspects of early diagnosis as far as safety, which in regards to cooking, responding to smoke alarms, falls, as I think we touched on last week. And how can we put out or talk about how to deal with safety aspects? I know that with my mom, early on, she was putting foil in the microwave. She was putting paper plates in the oven. And we kept taking things away from her. And so until she just couldn't be alone at all. And so the safety in the community, there's always that aspect of driving. As far as I know, my mom one time went to the grocery store, and I felt awful to hear that she couldn't find her car, and they ended up calling my brother. The store went through her purse, and thank God they did. And then we were able to retrieve her. But there's just so many aspects for safety and what's happening to them early on. And I know we talked about the early interventions and the early diagnosis, but those are just real true concerns. I also want to talk about what's happening in the Ohio Long-Term Services and supports relative. And I know that in the skilled nursing, which is my domain, which is my space that I function in, and it's 65% of those residents in long-term care skilled nursing services have a diagnosis of Alzheimer's and or a related dementia, even though their admission diagnosis is typically a surgery or a fractured hip or a wound or pneumonia, something else. And so we've talked ad nauseum about that training. And I think that's not still working well, and just wanted to reiterate that, although we talked ad nauseum about that last week. Those folks are very mainstreamed with everyone else, with people that are cognitively intact. And so, and with the short staffing, they're grouped in, and there's no special treatment, no special hands-on with those individuals, pretty much not at all. They're treated as everyone.
Pardon me for interrupting. I'm going to have to stop you. I'm sorry.
That's fine. Thank you.
Okay. Thank you. Thank you so much. Jen Drost, and then Joe and Leanne.
Good morning. From the safety and legal issues, kind of taking a little bit of different perspective, though I certainly agree with what's already been said, but kind of looking at, I guess, more of the legal issues and the advanced care planning supports for individuals with dementia, and not only those, formal legal medical documents, powers of attorney, those sorts of things, but really how those transition into training for our legal providers, from financial folks, from the risk of financial exploitation for those living with dementia, and training across those fields. I know that the Attorney General's office has been doing a lot of work regarding financial exploitation and how are we training people kind of on the front lines of evaluating that on dementia, but also how to assessing capacity in order to make financial decisions, across the board. And that dovetails then into, healthcare as well, in capacity assessments and understanding the decision-making capacity of folks from a legal, financial, as well as their medical standpoint, because a lot of risk obviously associated with those, and those the capacity along those different fields certainly varies from individual to individual, and over time home safety may vary different than their financial safety. Those deficits may develop at a different rate within individuals. So that was where some of my thoughts were, briefly.
Thanks, Jen. Joe and Leanne, and then Director Ashenhurst. Joe?
Thank you. Thank you, Jen. That was very well said. I would just add to that some detail on the power of attorney on the healthcare side. I think it's really important that there is resources available to families about what type of healthcare decisions and planning can be made early on in the diagnosis, and that there's also training available for caretakers and providers on these different aspects from the legal perspective. We, from time to time, see, although it's not necessarily prevalent, we see providers, especially the in-home providers, who maybe are being dragged into family disputes and family conversations around healthcare, and they're really there to provide healthcare. They're not suited to necessarily provide any type of opinion. But we think it's really important that people in the early stages of this are not only part of their healthcare making decision about what they want to see, but also they start talking about end of life care decisions, because a lot of times if those decisions wait till to the very end, they can be very emotional and very difficult. So the more resources available to families and individuals and providers regarding the healthcare aspects of power of attorney would be really great. Thank you.
Thanks, Joe. Leanne, Director Ashenhurst, and then Bonnie. Leanne?
Well, good morning. Again, I agree with all the previous comments. Several of my notes were some of those same comments. So one other thought that I feel is important is, and I don't know if there's a way to train employees, and I know this has been touched on a little bit in the past, but train employees at, Walmart, Kroger, whatever your retail stores are, and restaurants to kind of identify when there's a situation and maybe help people through that. Some, just personal experience with that when you were with someone in a store and they may be having an outburst or they may take something. It may be theft. Again, that kind of goes back to the first responders, but also some type of training or information for people as they're working in these environments to understand that these people can't always help what they're doing or know what they're doing. So again, just a little bit of thoughts on that. I also agree with helping families or loved ones with where they go to get that legal help that they need, and again, doing it early on. And again, making that person a part of that. We went through that with my own mom, and it's a difficult thing to do, but sometimes attorneys are leery. They want to make sure that person knows what they're agreeing to, and so doing that early and achieving that early is just so important. But I find sometimes people I talk to, they just don't know where to go. They don't know where to turn. I just talked to someone over the weekend who needs to get his wife on disability, and he said, I don't know where to turn with all of this. She has early onset. So those are just some of my thoughts. We've talked about it in our capacity committee meeting, having some type of clearinghouse where people can go and just learn. And I know there are places out there. I know they exist. It's just, how do we get that information out to people that need that on a daily basis?
Thanks, Leanne. Director Ashenhurst, and then Bonnie, and then Lisa. Director Ashenhurst, are you still with us?
I am, and not wanting to echo what everyone else is saying. The power of attorney is super, super important, as we're realizing more and more in our veterans homes and people that we've let in. If we get it as soon as they're admitted to some institution or any type of hospitalization situation, it's just critical, because we're struggling with some of the after effects of that. But I also think that this whole idea of a Alzheimer's home, where information is captured, if we can start getting that into advertising and into public service announcements, that'd be very helpful. Thank you.
Thank you so much. Bonnie?
Hi, everyone.
Did I skip you before? I'm sorry.
Oh.
Okay, go ahead.
Okay.
Go ahead, sorry.
Four quick points. One is, in our state, we have some great examples of communities that are working together, and including law enforcement and the legal communities. So I wanted to make sure that everyone is aware that we have task forces in at least 3 communities. And maybe we can talk about maybe replicating those, or at least learning more about them. And these are task forces where legal and the public safety, everyone is a part of it. And those come from some of our grants, and some are sustained beyond the grant. So I think we should be studying those. Secondly, I want to make sure that we make the distinction between, when we talk about long-term services and supports, safety versus ensuring that someone is secured through a locked unit. I think that's up for debate of where or how we should be caring for those who are living with dementia. And I think we should be discussing it. Third is, I think it's very important that this conversation is nuanced, in that it's a slippery slope. If someone has mild cognitive impairment, or what the diagnosis actually is. Unfortunately, when most folks hear that someone has dementia, they make the assumption they cannot do certain things. And so we have to make sure that we are informing the public and everyone about the slippery slope and the nuances of dementia, so that we don't inadvertently make people too secure, because in this country, I'm not a social worker, but I know we do have the right to folly. And I want to make sure that we are kind of thinking about that. And my last point is, about 70 to 80% of the folks who are living with dementias are living alone. And so the importance of what happens in the community is very, very important. So thank you.
Thanks, Bonnie. We've Lisa Brockman, and then Greg, and then Lori. Lisa?
Yeah, thanks.
I think, between last week and this week, we've all hit on most of the topics. I will add, I know at one point I was part of a group that started talking about having some kind of sort of reservoir where that captured when folks are still living at home with Alzheimer's or another dementia, that then first responders would be alerted when they got a call that they were walking into a situation where the person was living with that diagnosis, and therefore hopefully would adjust their approach accordingly because of the training we're likely to recommend that first responders are getting. So, I think that's something that could be really, really beneficial for those still living at home.
Thanks, Lisa. Greg, and then Lori, and then Sally. Greg?
Good morning, everybody. It's good to be on. Mine relates back to personal and public safety, really leaning heavy on transportation for seniors that are struggling with some type of cognitive decline. We watch families wait often too long to take the keys away from their loved one. I'm in that same situation myself, and it was the hardest decision I had to make, was taking the keys away from my own mother, knowing that she was fairly independent, but just it wasn't safe. And we're struggling to find transportation. She actually is currently living up in Canton with my sister, and I would love to be able to have a service that we could call. They would pick her up and take her wherever she wanted, and then bring her back home safely. I know there are some programs out there. It's just they're not all readily available. And I think if we focus and make it easy for families to help their loved one through that transportation process, I think it'd be powerful. And then also just to sort of go back to what Dr. Drost said related to POAs, we see a lot of families that there's strife when it comes to the finances and the cost, especially to move their loved one into private pay. And sometimes they make wrong decisions on behalf of their loved one just because they don't want to spend the money that their loved one actually earned over a lifetime. So I don't know if there's something that we can do there to help guide and protect those types of decisions. But yeah, those are two things that I thought are important.
Thanks, Greg.
Yep.
Lori, and then Sally and Jean. Lori.
Thank you. I think I'm going to just echo a couple of things that have already been said in the notes that I put down. I really think that a better follow-through process when we trigger concerns about driving. Right now we can report to the DMV, but I feel like things just don't go far enough. Like we're hinting at the tip of the iceberg. We're telling families your loved one can't drive. We're taking keys. We're notifying the DMV, but then there's really no follow-through on the back end of that, whether it's giving them alternative resources, like Greg just mentioned about transportation options. So it's sort of like saying to a family they can't do it, and good luck. And so I just think we need to do a little bit better job with like looking deeper at, well, we recognize that driving is an issue. We recognize we need to trigger and get evaluation sooner. And then what's the follow-through process? And I think the same thing comes true with capacity evaluations. Oftentimes, by the time an attorney targets a family member's concerns about capacity for their loved one, they reach our office too late in the process, or we're doing them post-mortem. And that's where I think a lot of our seniors get exploited. And then trying to unravel that is very difficult. So I think when we talk about capacity evaluations, we need to do a better job with our attorneys, our frontline staff, our physicians as to when to trigger for capacity evaluations. And I'll just finally add that I think, Bonnie's point about these are nuanced conversations. I think they absolutely are on both ends of the spectrum. When we say dementia, we formulate assumptions about what a person can't do. And when we say early phases of dementia or mild cognitive impairment, for some people, we make assumptions about what that means. And judgment is a huge issue in that. So people can, still have some of their cognitive skills in play, but if their judgment and their ability to execute those decisions is impaired, it doesn't really matter where they are in that form of the disease process. Those are the things we need to be taking a closer look at. Thank you.
Great. Thank you. And Director, did you have a comment?
I did, and actually some of the things were said, so that's a great setup. So when you asked the question about safety and legal, I broke mine out into both civil and criminal, because I think we do have to bifurcate them. Otherwise, we'll lose some opportunities here. And what I would say around the civil, what's working well and should continue, there has been a pretty thorough review over the last several years around the probate court's handling of the guardianship and conservatorships. That being said, I do think that in terms of areas of improvement, up to the points earlier raised, making certain, one, that the court has time enough to review as often as enough and as closely enough so that we are utilizing the lesser restrictive alternative. Right now, we have some pretty extremes that we utilize. Either there's a finding that you're incompetent or not, and there's a lot that can happen in between there. And so having an assessment that is much more built on capacity and the resources to actually do that is going to be important. Second, on the criminal side, I do want to bring this up. Many individuals who are even at the early onset or have mild cognitive impairment are susceptible to and can be vulnerable to financial exploitation and a fair amount of things. It becomes very complicated when you don't have someone who understands and appreciates that, because remember, our bar is set really high. And with that bar, oftentimes you will hear A, they don't believe they're a good witness, and so they don't pursue things. B, because they haven't reached the level of what we deem incompetent, then it is deemed a civil matter and it doesn't move onto the criminal side. This is a problem for a lot of reasons. So what are our opportunities? We have the opportunity to build forensic capacity. We do not have that within the state for older adults. However, we do have good examples of it within the child advocacy centers. Multidisciplinary teams who have skilled forensic interviewers who can interview and gain that information that can be useful to a law enforcement entity or a prosecutor's office so we can move these cases forward. So from my perspective, it's an infrastructure issue, both civil and criminal.
Thank you, Director. And for the moment, I thank you. I can't see that chat. If I try to open it up, it closes the window that you all need to look at. So, so feel free also to raise your hand. I'll try to keep an eye on that as well. And Yonda pinged me as well. So thank you for that. We have Sally and then Jean and Doug. Sally?
Okay, thank you. Not to reiterate, but I think working in the community, looking at what we can do to support individuals who are living in their own homes alone, to provide them safety and security, I think is really important. So I don't want to reiterate what a lot of people said, but I mean, I think that's a huge an issue where we could be very proactive and continue to support people because of the lack of diagnosis and the high number of people that are living at home alone. I know one of the issues, because I know that we've talked about driving, two issues that sometimes we've dealt with too that I think could be a training issue with first responders, excuse me, is sometimes shoplifting issues come up as well as firearms. So I think that's something with it, if you like kind of dig a little bit deeper into the safety issues, those are two topics that we are frequently addressing with families. Not so much the shoplifting, but it does come up because it's really kind of a traumatic experience for people when that occurs. And then there are a couple prosecutors' offices throughout the state. I know there's one in Lucas County where I live that have a prosecutor that's specifically assigned to work with elder abuse issues. And I know that unfortunately he spends a lot of time working around the financial exploitation. So I think there are some models out there, right, even within our own state that work with older adults that could be helpful for us with older adults and individuals with dementia. I think that may have been about all on my list, so I'm not repeating what other individuals have already said. So I'll yield the rest of my time. So,
thank you, Sally. Jean, and then Doug, and then Pete. Jean Thompson.
Thank you, Leanne. I agree with many of the things that have said, and they've been excellent. I will say that I think in addition to the groups, the first responders targeted for this education, I'm a big believer that just building cultural and community awareness of dementia would help. In other words, as I've said, I think in relation to other topics, that I think there ought to be, we're built even in the educational process. I believe the numbers of people in this situation are going to be so large in our society, it would be well worth a small segment through the Board of Regents that just let everyone know, so that your supermarket checkout person had an idea of what dementia was. We need more spotters. We need more feelers, not just the first responders. The community I live in utilizes mail delivery persons to report if there's something that seems amiss, etc. I think that in addition to specific targeted education, building a community-wide awareness would help us moving forward in these areas. So that's really what I wanted to add, but I agree and concur with many of the items said. And I really like the director's comment that there's a big space that isn't addressed between really incompetent and competent. And there is nothing in that in-between space. Thank you.
Thank you, Jean. Doug, and then Pete, and then Trey. Doug?
Yeah, the space between competent and incompetent is the space that we got into with my mom. My brother had paid her mortgage for almost 20 years, and she got the wild idea that she wanted to refinance without telling anybody. And so she took $50,000 out of the house, and there you go. We were trying to figure out what we could do from a legal perspective, and because she would pass most of those tests, it's a real issue. So it would be interesting if there is some help up for families that are worried about their loved ones who are making bad decisions, but by most measures would not be considered incompetent.
Anything else, Doug?
No, I was trying to be short.
Yeah, just making sure. I didn't want to cut you off. Thank you. Pete, and then Trey, and then Senator Wilson. Pete.
Thank you. I was able to speak last time on this topic, so I'll be very brief, but I was struck by Greg's comments about transportation, because that really applied to my mother. She ended up losing her license because she got lost on a trip to Pennsylvania. That's like a 9-hour trip, and it took her 27 hours to return. But after that, she refused to stop driving. And so I eventually had to take the keys. She had 5 sets of keys hidden in her apartment, just in case that happened. And she kept using them till eventually I got them all. I had taken away her handgun previous to that, to the point about firearms. But once all the keys were gone, what she did was then she started asking random strangers. She lived in an apartment, a normal apartment complex, not a senior's place. And she would just go up to anybody she saw outside and ask them if they could give her a ride someplace. So speaking of safety, that is, she wasn't driving her car and being unsafe that way. But since there wasn't a good alternative for her, she didn't call me. She would do something that was equally unsafe. So I think, that's something that really needs to be addressed, because that car travel is a big deal.
Thank you, Pete. What a terrifying story as well. Of experiencing that with my stepmom. It's just terrifying. Thank you for that. Trey, and then Senator Wilson, and then Vice Chair Diefenheimer.
Yes, I'll be brief as well. I think I spoke a little bit on this topic previously, but I think the one area that we've seen just at the Alzheimer's Association is really public awareness. The reality is people don't know quite frankly, what dementia is in some instances and what the differentiation is between Alzheimer's and dementia. And number two, on to that point, is when we start to mix the two or have conversations, especially we've seen with families, I mean, there's a big difference. I mean, some people don't want to talk about it. So the more we can talk about it overall as a state, I think it helps everybody as a state. I think the other two things I did hear first responders. There is legislation right now as it relates to training for first responders, is House Bill 23. From our vantage point, I think that's a good first start. However, I mean, of course, when it comes to firearms, that's another area where we looked at in adding some sort of, some sort of ability to see what we could do around that within the legislation. It just didn't make sense. But that is an issue that we've heard time after time from families, is as their parents, mom or dad, get older, it is complicated in some instances, so especially with those individuals with early onset, to get their firearms taken. We've actually just recently had a case where, I mean, literally, it was a very, very challenging situation within the family. So, as we can imagine, that's something that we definitely need to address with someone who has cognitive decline. But I think, looking at first responders is a good first step. And I think we're hopefully going to get there and get it across the finish line.
Thank you, Trey. I have Senator Wilson, Vice Chair Diefenheimer, and then Ombudsman Laubert. Senator Wilson?
Well, thank you so much. And I appreciate all that all of you do. It is striking to me how many people we have and how many organizations we have out there trying to take care of our elderly, and particularly our elderly with Alzheimer's and dementia. But I think there needs to be better coordination. And my dream would be, if I go up to 30,000 feet, that we would somehow know those who are living alone with dementia. And once we do that, we would somehow have a file that said, here's how that person is going to be checked on daily. Is it Meals on Wheels? Is it a first responder? Is it Adult Protective Services? Who and why? But we need to know that everybody in their home alone that is with dementia of some sort is being checked on daily. How do we do that? To me, that's the essence of what should be in our report. Is it Adult Protective Services that coordinates that? Who coordinates that? We have a zillion different people doing a wonderful job, but I see a lot of people falling through the cracks. And that would be my observation. Thank you.
Thank you, Senator. Vice Chair Diefenheimer, and then Ombudsman Laubert. And I also noticed that Jen and Catherine have joined us. So we'll get to the end there, and I'll check and see if anybody else. But Vice Chair.
So everything that has been said, very, very great. I don't want to reiterate a lot of things, but some of the things I did want to add to was, as far as the first responder and the training and how essential that it is, but also to make sure the component of that caregiver part is included, because when the first responders are responding to a caregiver, it gets very complex if they are the caregiver for the person with dementia or Alzheimer's. So having those resources, and not just even where, but what are those next steps if they're removing that person from the home for a medical emergency. The other thing is, with the power of attorneys and having a simple process and understanding for people not to be aware, because a lot of times that might come later on when you're already in process. And so how do we educate the public to understand how to kind of what is needed before, but also work them through the process in an affordable way, so they can access and have the right protections that they need in place. I think, and just, the financial part, I think we've talked about the private pay and kind of the choice when you are kind of having to take your loved one into kind of that scenario, when you're no longer able to care from the health, and it is very expensive. And so even though you may have the resources, you have to think about, well, what's it going to be in 5 years, 10 years, who knows? And that can be very challenging, even when you do have resources of how do you plan for sometimes up 20 years the road. So all those kind of supports that we could have put in place for families and caregivers.
Thank you. Ombudsman Laubert, and then Jen and Catherine.
Hi, everyone. Just a couple of comments about the power of attorney issue. There has been some advocacy to educate attorneys who are helping people execute powers of attorney to educate them about capacity determinations, especially if someone's coming in to change a power of attorney or change the person they're giving authority to. There have been so many situations where a family member who isn't power of attorney takes their parent in to an attorney and has them change a power of attorney and change a will. And so there are lots of opportunities there for exploitation, especially in the early stages of dementia. And so there has been some advocacy. I know Director McElroy will remember one particular individual who contacts the Elder Abuse Commission quite frequently through the years about that issue. So I think that that's important. And also, and some may have alluded to this, but I just want to be really clear, powers of attorney do not all look alike. There are durable power of attorney for healthcare. There's a general power of attorney to sell the house. So when we're talking about powers of attorney, it's important that we're very clear about what is the authority of the individual, that someone with dementia or anyone has appointed. The power of attorney that my husband has for me is very different from, what I might give him authority to do in different circumstances. So I think that that's important and some good education, because sometimes ombudsman will get a phone call from someone and say, well, I'm the power of attorney. Well, but what do you have authority to do? You don't necessarily have authority to give us permission to look at your mother's records or for us to use your mother's name in talking to a facility to resolve a problem. So we educate our ombudsman about that all the time. And then the other thing that I had mentioned at the last meeting that I wanted to say a little bit more about is the reporting of missing adults. In the minutes, it's called Silver Alert. That's not what we call it in Ohio, but the missing adult alert system. We need some better consistency in that system. We need law enforcement to have better criteria for reporting to the Attorney General's office, and the Attorney General's office decision-making process on whether to issue an alert or not. So many times it's like after the fact or after someone's been missing for a while. And then there's also lack of clarity in long-term care facilities about whether they have to report to the Ohio Department of Health when a resident is missing. And I believe we need to change the requirements and require that when a resident is missing and not in the facility unexpectedly, that should have to be reported to the Ohio Department of Health. It's too risky to wait and expect that the facility is, working on finding the person, and then several hours pass and we've lost opportunities. So I think that needs to be clarified as well. And I think that's it for now.
Thank you. Jen and then Catherine.
Well, good morning, everyone. I wanted to mention just one thing that has come out of Project Echo, out of the Mayo Clinic in Minnesota. They created for their patients a local guide to resources that someone with dementia might need to acquire. So those could be, everything from attorneys that work in elder care issues. It could be transportation resources, meals, nutritionists, exercise, any of those kinds of things. And they did it locally
through, using their hospital system and their patient profile, because those resources are so localized that a booklet for somebody in Mayo Clinic in Minnesota may be really different than a hospital in northern Minnesota. So they recommended, Mayo Clinic has recommended that hospital systems consider doing something similar. I did put that in the chat, and I believe that we have posted, probably under the Experience Committee, a table of contents for what that resource guide could look like.
Thank you. Catherine.
Yeah, apologies for joining late. I had a conflict this morning. So in joining late, if I say something here or start into something that you've already discussed, just stop me. But one of the things that came up in the Experience Committee that we were really challenged by was the Lake Health report, where they had done research within their own system and learned that less than 1% of the 65 and ups had any record of any screening being done. So in terms of where we could see improvement, that system saw the need for them to be far more diligent in doing a screening. And so attention and thought around what that might look like with more diligence would perhaps get us at least a little bit further down the road toward what Senator Wilson was envisioning, which was having a way by which we could check in frequently with people. Part of the problem with that is just simply knowing who and then figuring out the how. But that research was really compelling to hear that there was such a low percentage in a system that was fairly committed to this, which is why they were researching it. So wanted to bring that up.
Thank you. I'm going to loop back to Tina, who I think may be on the line with us now. And
hi, yes, I'm here.
All right, Tina. Do you have anything you want to add?
Can you hear me? Yes.
Yeah.
Can you hear me okay? Okay. I agree with the increasing with the transportation and providing more services out there for family, individuals, and healthcare providers. I also agree with Greg. I think he had a good point talking about finding easier transportation for our loved ones. You know, one of the biggest things is taking those keys away from our family members or loved ones. And I think if we had easier transportation out there, that maybe it will allow the resident or loved ones to feel like they still had some kind of independence rather than a punishment. Because that way, you know, if they're living at home, it would give them the ability to, you know, independently call transportation or get around by themselves and not feeling like they rely on family, or so that way they could feel still independent as well. And then I also agree with we need more in like education from physicians with the early detection. Fortunately, my father-in-law, who was a retired physician out in Dayton, he had clear cognitive deficits, and every physician he went to, they would not diagnose him with anything. So, you know, that was hard for us to get any kind of services in or offer help because he masked all of his cognitive deficits, and he did a very good job at it. But he would not let us help on anything. And then he ends up meeting a woman who took advantage of him. And unfortunately, she took $500,000 from him in 1 year. So it wasn't until it got really bad until we could take him out of that environment. But I felt like that could have been prevented if something was more in place. Thank you.
Thank you, Tina. And it looks like Representative House, you've been able to join us since we started. Are you with us?
Oh, yeah, I've been on for an hour now. But
I'm sorry. I was just scrolling through the list here.
I'm about to get off now because I need to check in with what's going on with the conference committee. But just for my 2 cents, I just really think that we, from the perspective of being a policymaker, there's got to be, I just think, a better way the cost, again, I will always say the cost of doing nothing, and a lot of this is steeped in policy. And as we are talking about all of the safety issues, all of this stuff, there are some rules somewhere that legislators have a responsibility. And I'm not just specifically just talking about on the state level, but as we're even looking at local and county policies, I really think we have to do a better job. I'm really just trying to give the relevant information to legislators in a consistent basis, because the turnover in a lot of legislative bodies is high, and so you're always playing catch up to turn things over. And I agree with everything that everybody else said.
Thank you. All right, let me just check and see if I've missed anyone. All right. Great. Well, thank you all for your contributions to that part of the conversation. All right, Yanda, do you want to speak at all to data that we either still need or we are aware of that we currently have around safety? I'm going to just safety and legal for easy language here.
Sure. We have still kind of limited resources in this area, data resources in this area. I have certainly, we've been flagging some things that have been appearing in chat, so we will go back and take a look at that. I've also been flagging some comments that a couple of individuals made, so I will do some follow-up emails, but there certainly is national data in many of these areas. I'm just not sure what's available in Ohio, or that is specific to the picture in Ohio. And so, we're hoping to assemble more information to support these conclusions. Although, as we've said multiple times now, there may be conclusions that part of the finding is we need more and better data. So I won't belabor that point. I think we can go ahead and turn it back over to Leanne.
Let me just ask if anybody has anything to add before we move on to the next topic. Next topic is early intervention. Time-wise, we're doing well. It's about 10 minutes past where we were hoping to start, but we're fine. We will take a break at about 10:30. So whoever will finish at 10:30, whoever's talking will take a break, and then we'll come back and continue, just so folks know that. But anything to add to this conversation before we move on? Okay, so we're going to move on to the bucket. Oh, I'm sorry, Doug, go ahead.
Yeah, I apologize. For whatever reason, my electronic hand won't come up. So, I've always found Bob Applebaum and the folks at Scripps very, very, very helpful when it comes to missing data. I don't know how that arrangement would be made, but certainly they're one of the most recognized organizations in the United States with respect to aging issues.
Yeah, we found a wealth of data from them. It's been really, really helpful. Thank you for referring us to them. Okay, so one of the buckets where we combined some information became early intervention. And you can see the subtopics that are here, the sub bullets, C1, C2, 12, 13, and then B8. So there's policies and strategies around increasing public awareness, policies and strategies around encouraging improved detection and diagnosis, policies and strategies promoting activities to maintain and improve brain health, policies and strategies for improving the collection of data and information related to the disease and the public health burden associated. And then the last one is existing resources, services, and capacity that's being conducted at universities in Ohio. And again, the same kinds of questions that we started with before, go back here. What are you aware? What are your observations about what is happening? What's working well? What should continue? Where do you see a need for improvement? And can you draw some conclusions and findings? And I'm going to start with Jean, and we'll go to Jean and then Sally and Doug. Jean Thompson.
Thank you. Well, I guess for me, once again, I go back to the education, but general education, just a knowledge of it, maybe to even remove some of the stigma of it. I think something in the schools would be a great idea. And we're doing that with lots of things now. And I mean, I think one little segment would be great. I also think that because it would provide general information so that so many of those people that interact with people who are suffering from dementias would be able to interact better. I think we ought to utilize, when you talk about brain health, maybe we could better utilize public resources already in existence, like for those people who are living in the community, like libraries. Maybe they do a morning a morning come, it socializes and might help with brain health. They do a morning puzzle club. They do a morning events club. I mean, publicizing it, having them do that, having the senior centers make more and better efforts at doing that. I think there has been some efforts, I think in the cafes that have been mentioned in some of the subcommittees, etc. But I think we're going to have to, Mina and I, quite frankly, and I'll put that in the chat, but I think, the mailmen go to every house. When Senator Wilson was talking about every house, actually here in Arlington, where I live in Ohio, they have that service that basically if the mailman notices for 3 days nobody picked up the mail, or suddenly the place that used to be immaculate isn't, they call the city and let the city know, and call help will call that particular individual. I do think that there is a big group of people who are old, not necessarily old, but who are elderly and living with dementia at some level. And it is hard to reach them because we aren't even hearing about it necessarily through families, etc. So we do have to develop ways utilizing probably existent resources of reaching those people. Thank you.
Thank you, Jean. Sally, and then Doug, and then Pete.
Okay, great. So just to mention, I know Jean talked a little bit about senior centers. I think senior centers would probably be a great place of early intervention. I know that in the state of Massachusetts, there's a model for memory cafes, which I think have been pretty effective with early intervention with groups. And it's interesting because those reach different communities in both urban and rural areas, and really focus, I think, on a community partnership network so that the reach can be pretty broad throughout communities. So that may be an effective program to take a look at for earlier intervention. In Ohio, I know the Dementia Friends Net program is being delivered throughout the state and collaborating with many different sectors, which may be another source that's already existing in the state. And then we do have a number of ACL grants. My organization is part of one, but and there's several other ones around the state that are looking at early interventions, particularly for individuals with intellectual and developmental disabilities and dementia. And so that may be, they're looking at other target segments too, like people living alone. But I think there's some really great learnings and collaboratives going on throughout the state through those projects. And those are through the Administration and Community Living, and the National Alzheimer's and Dementia Resource Center has a lot of information about early intervention in brain health too. So that might be some good models. And then, I think continuing to pick away, as Jean had mentioned, about getting people, that might be falling through the cracks through some more innovative approaches such as mailmen, etc. So.
Thank you, Sally. Doug, and then Pete.
As many of you may know, I worked in the Florida system for 15 years, and as I recall, we did a lot in testing, particularly in the Alzheimer's Disease Initiative, using programs like Mini-Mental. I don't know that we do that here. It seems that the testing isn't quite as advanced, so I would think that maybe as we're starting to talk to these adults within our screening process, we may want to look at doing other types of tests.
Thank you, Doug. We go to Pete and then Lori and Greg.
Thinking about this from a family perspective, I was really struck by Tina's comments about, I believe she said her father-in-law. You know, that's in my mind, that's one of the real challenges is that, and we've been talking a little bit about, you know, identifying people, but when the family's involved, I mean, they've kind of identified, but what do you do next? And getting some advice somewhere where you could get advice on how to handle your particular situation, which everyone is different. And so, you know, some, I guess, customized advice on how to deal with it. And also to understand or communicate the understanding. I believe it was Bonnie Berman who mentioned, I don't remember the words exactly, but it was like, you know, we do have in America, the dignity of risk, and that people have the right to make their own decisions. And how do you know, put those two things together, understand them, and be able to be as helpful as you can? I think that would be my idea or thought.
Thank you, Pete. Lori and then Greg. Lori, you're on mute.
So I guess that's not useful, huh? So I wanted to go back to something that Jean mentioned earlier, and I think is really an important component. We have focused so far on identifying professional subcategories, you know, the law enforcement, our physician groups, to be aware of early detection and identification. But I absolutely agree with Jean that it's the people who are out in the community who see a senior driving up over the curb or, you know, forgetting something in the grocery store that they think that's really, I'm concerned about this person, but they don't know what to do with that. So I think having those spotters who are well trained, I love that word, Jean, spotters out there in the community, who feel empowered and educated to advocate for the seniors that they see. And then I think Senator Yuko hit on another important part, which is we need to have a clear identification that once we identify which of our senior organizations is going to own the responsibility for each of those different subcategories. And those organizations have to be well funded. I know one of our biggest struggles has been with adult protective services, that they're mandated, but they're not well funded. And so typically cases don't get opened. And I think that's part of then the resistance of care providers saying, you know, well, we're not going to send them to protective services, so because nothing's going to be able to be done with the number of cases and the inadequacy in their funding. And so these are clearly our seniors who are at the most risk and most vulnerable. And I think we end up tying each other's hands because we don't have a good, clear process of which organizations that provide senior support is mandated and educated to provide each of these different services. Thank you.
Thank you. Greg?
Yeah, I'll just start with, I think that we somehow need to get a message out of hope that if things are detected early enough on, there is things that you can do to combat against most forms of dementia and cognitive decline. So I think message of hope is important. And then just so you know, the youngest we've had at a Kemper house is 48 years old. If we would have had some type of system to really detect in their early 40s, as often as they get a physical checkup, they get a cognitive checkup, and at those early ages, it goes beyond like the Mini-Mental and the MOCA, because those are more symptomatic tests when you actually are dealing with it, and it's just more pronounced. But there you can do a blood panel testing and genetic testing and different things early on that can help detect things before it reaches a level where it's much harder to reverse the effects of dementia or cognitive decline. So I think just most people that I speak with, we're big about brain and body health and prevention and keeping people out of a building like ours. I really talk to them about hope. Don't be afraid of this. It's like cancer. The earlier you detect it, the better off you're going to be. And so I think it's just a matter of getting the right message out there and then creating standards of detection within our healthcare system that's going to give us the best results.
Thank you, Greg. And I apologize. I usually try to cue folks up so you know who's coming next, and I forgot to do that. Ombudsman Laubert, Jen, and then Trey.
So I think it's a fine line we walk. We don't want overkill. I think one of the reasons people don't want a diagnosis early is because of fear of how they'll be treated. Will someone, once they hear they have dementia, start talking about, well, we're going to have to find a nursing home because someday they're going to decline and need a nursing home, and we should take advantage of that opportunity to educate people. I didn't say earlier because I was running out of time. On the other topic that I think we do need to have, this group isn't going to be able to do it, but a clear recommendation from this group that we have a serious conversation about what we call memory care and getting rid of locked units, because our system is set up to make people afraid of what's going to happen if they have a dementia diagnosis. So we have to make sure the system is set up correctly for people with dementia at all stages of the disease or symptoms. And so they're not so hesitant to go to the doctor if they're starting to notice some memory problems or families starting to notice some memory problems. So it's kind of like we need to look at the future and what happens at the other end and make that a less fearful, fear-inspiring capacity than what's available in the community, for example.
Thank you. Jen, and then Trey.
Hello again. The early intervention topic is really meaningful to my husband and me. Rod had some testing done in his mid-50s because of traumatic brain injury that he probably would not have had done otherwise. And that early imaging, in particular, PET scan, MRIs, is what helped us to navigate our way to a dementia diagnosis. Rod was put on Aricept very early. That's the initial drug used in the earlier stages of dementia. It was followed up by Namenda, adding Namenda probably about a year later. So he has benefited from the protocol that could be applied with early detection. Both of us at this point are very grateful, thinking that his cognitive neurologist told us with the last appointment that he may not be as far along in the disease as originally thought. And, that's huge. And we're kind of wrapping our heads around, well, what does that mean in terms of our plans? But that whole idea that somebody would do cognitive testing with him and help us to direct his care based on the results was probably life-changing for us.
Thank you, Jen, for sharing the story. Trey.
Yes. So I know Project Echo was brought up earlier. I think Janet brought it up. One of the things, just kind of going through strategies and policies, one of the things that we've seen that's working, Lake Health was brought up as well. A lot of that work came about through the Alzheimer's Association Health Systems work, where we've got staff that are literally going into health systems, working with them and trying to reverse a lot of the old antiquated systems into a system where early detection is the focus, especially at the health system level. A couple other areas where solutions can come about, I think, is really looking at hospitals and developing a dementia-specific operational plan that speaks to care coordination, that speaks to early detection, and some preventative measures, et cetera. But also, really looking at the development of statewide infrastructure that supports early detection and diagnosis. We continue to talk about it, but to be honest, I think until it is on the books or in some mandated fashion, whether that starts with physicians or whether that starts with requiring our facilities, mainly hospitals and health systems, to start to tackle that, I think we really won't get too far, just to be quite candid, with early detection, because you have to get to scale with it in order for it to work. And the health systems are seeing more patients than anybody. Their practices in the community, they're acquiring practices in the community. So when you think about who has the biggest scale, the largest scale, and the ability to impact more lives as they come through a system, that's where it starts. And we, not only do we see it based off of the data we see, we live it every day, based off the people that we interact with. So I think as we look at that, that's kind of a big area for us, and we're moving in that direction as a country from an Alzheimer's Association standpoint, but it has to get to scale. The last thing I'll say is around really going back to public awareness and identifying diverse communities to do that in. One of the things, I think, the stigma with a lot of communities of color across the state and across the country is no one wants to talk about Alzheimer's and dementia. So in looking at that and in looking at communities, diverse communities across the state, and even when we say diverse, beyond communities of color, looking at rural communities as well, really directing public awareness dollars to those communities to help with awareness. So again, going back to it, health systems is a starting point, and obviously public awareness is a secondary point.
Thank you, Trey. It is 10:29. I'm going to suggest we take a break. I've been sitting for a long time. Let me just ask really quickly. On my end, my chat light is blinking, but I can't pull it up without clearing everything else that you all are looking at. Is there a question in chat that I need to respond to, or we need to ask somebody if they want to go ahead and share because they need to leave early or anything like that? If anybody can see the chat.
It's looking like the chat messages are just kind of checking in with attendance. We had a few that needed to pop off for other meetings. A request to scroll up. So I think we're all good. I think we're caught up.
Okay, thank you. Thanks. I can fix that when we take a break. But all right, so I have 10:30. We're going to take a 10-minute break and come back in 10 minutes, whatever that time your computer says, in 10 more minutes. All right, thanks everybody. Okay, I have 10:40. And on my screen, it looks like a handful of folks, a pretty big handful of folks are still off camera. I'm going to go ahead and get started and see where we are. We're going to continue the conversation about early intervention. And we will start with Lisa and then Bonnie and then Senator Wilson. Lisa, are you back with us?
I'm back. Yeah. I think we've touched on this. Everyone's touching on most things, but I think a public campaign, you know, and if we are going to go down the route of having a complete sort of billboards and all the things saying, you know, concerned about someone you love, surrounding cognitive or memory issues or however we want to word it, with some kind of 800 number anyway, that then gets them sort of pointed in the right direction, right? So it's this place that they at least can get started, and hopefully then we can get them set up with people who can do the half-day assessments and really fine-tune their individual plan for them and their loved ones. I agree that it should be a message of hope, and that sometimes the end situation of a long-term care community or even an assisted living community can seem daunting, but that the people who go through this the most smoothly are the ones who have had the time to consider all their options and come up with a plan that best meets their family's needs and desires. And so that when, you know, our behaviors or another acute medical need or a fall or something dramatic happens, they're not having to, during that crisis moment, think about what their next steps are. So I really think sort of giving them a place to start as early as possible will be key. I know we've already touched on some of the places that's happening, but honestly, some people aren't going to the doctor for their regular visits, and you know, the mailman might not notice if they've got a mailbox instead of going to the door, those kind of things.
Thank you, Lisa. We'll go to Bonnie and Senator Wilson, and then Vice Chair Diefenheimer. Bonnie.
Thank you, Leanne. I wanted to build on a couple of points that people have already raised. The first is Trey talked very well about a statewide infrastructure and the role of the medical system. And I want to just drill back a little bit with that, and that because we are blessed in Ohio to have an incredible state-supported medical school and other health profession schools, and we spend a lot of money on them, and we have graduate medical education and others that we are paying for. Yet we haven't really focused on the education and training that our allied health professional students and our professional students are receiving. And we need to get that information. I think we all know that it's going to be lacking, but it's extraordinarily important, and we can't count on healthcare systems to take care of it if we haven't educated and trained folks. And the second part of that is continuing education, of course. I also wanted to bring up the whole idea of the stigma that so many people have brought up so well, that we can't have kind of a one size fits all, because there are so many cultural groups that see it so very, very differently. And that gets me to the whole idea of how many languages we are speaking here in the state of Ohio, and how we can adapt and adopt some of these strategies to meet the various needs of not just racial, but some of the ethnic groups that are going to say, I'm going to take care of mom till the end. I would never go to a long-term care organization. And we have to address that. The last thing I wanted to mention was that we are working here in Ohio very closely with the Memory Cafe folks in Massachusetts. And I agree with everybody that there is a wonderful opportunity for us to come together and do more. So thank you.
Thank you, Bonnie. Senator Wilson, and then Vice Chair Diefenheimer. if you're still on.
Thank
Senator Wilson.
you. Yeah, thank you. This is Senator Wilson, and I have been aware of something as we have been talking and giving our ideas of how important being sure we're checking on everybody that's living alone in their home health care, education. We talk about early detection. We've talked about assisted living and memory care units and the funds that are needed there. We've talked about long-term care, nursing homes, the number of beds that will be needed, what the cost of that is. And being a former banker, I'm struck by the fact, as I do the math, that we have the potential to spend the entire budget of the state of Ohio on this issue. I'm not saying that there's not a need there. I'm just stating a fact. So I think one of the important things we'll need to do within our report is to talk about the importance of all these things, to look at ways that we can change without additional funding. But then for the funding that we need, which is going to be great, we are going to need to prioritize. If we don't prioritize, it'll be so overwhelming to the legislature that I'm afraid it will not get addressed in the way it needs to be addressed. The whole idea of this study was to know what the financial impact of the growth in Alzheimer's and other dementias in the state of Ohio, what the financial impact would be on the state. And I think us prioritizing will get a lot more done than if we just make asks that meet or exceed the entire budget of the state of Ohio. Thank you.
Thank you, Senator. And I lost track of my list. I'm sorry. Vice Chair Diefenheimer, are you still with us? Just making sure you're not on mute. Okay, I'm going to go to Dr. Jen Drost, and then I can't also see on my end if Director McElroy is still on. So we'll start with Dr. Drost and then see if Director McElroy is on.
Okay, thank you. And certainly apologize if there's some repetition here. Got pulled away for a few minutes. As far as the early interventions from, certainly we've talked a lot, I think, about memory cafes and awareness within the public realm, which is critical. Medicine and healthcare also being very vital to that. And I think one of the things that I see a lot is a lack of understanding or awareness of how, again, those kind of risk points early in the diagnosis that can have longstanding health and functional ramifications. So those early intervention points of really looking at how dementias and that cognitive impairment impact the medical care, health, wellness, safety of individuals in the home. So providing education and looking at how medications are managed. I don't think that's something we really talked about, but what a risky thing that is. Somebody taking too much medicines, not enough of their medicines, and then their health conditions get out of control. And we know that those acute health conditions, a new stroke, a new heart attack, an infection, all of those things have that potential to significantly change the course of that person's dementia care. Falls and falls prevention flows right into that too. So recognizing that both from a public as well as from a healthcare standpoint, that while a person may still, again, have that capacity and ability to live independent and to navigate those things, these types of risk points are important for us to address and to look at. We often hear from folks as you're giving them, a diagnosis of dementia, particularly other dementias and not Alzheimer's disease, but of like, oh my gosh, at least it's not Alzheimer's, but really not appreciating how that, impacts the rest of their healthcare. So I think that's one of those thoughts from the early intervention phase is, again, to recognize that even early in the disease, those other health pieces can cause a tremendous amount of change for an individual.
Thank you. Director McElroy, are you still with us? Don't see her on the list right now. Okay, just wanted to check. I am going to then go to Catherine and Diane and then Jen Blau. Catherine.
So during our 10-minute break, I was doing some frantic Googling, trying to make sure my memory was correct on this, but I was reminded of work that was done by a former employee, or employer rather, of mine, the Mather Institute on Aging. And my memory was that Mather, 7 years ago or so, had done work for the country of China on making sure that employee benefits packages incorporated caregiving and aging issues and resources. And it it came back to me as we were discussing this, because having employee benefits packages incorporate at least education and identification of the resources would be a tremendous opportunity to get information in employees' hands, and also raise a sensitivity of employers of the importance of providing resources for employees. So I wasn't able to pull it up quickly, but there is a model for this from other countries. So just wanted to put that out there as a potential early intervention possibility.
Thank you, Catherine. I have Diane, and then I had Jen, but Jen, I think I started with you actually. So I'm just looking at my marking on my list here. So Diane, and then Tina and Pam. So Diane?
Actually, I'm really glad that I went after Catherine, because that's a fascinating wrinkle. That's what I was going to talk about was stigma, and how much of stigma, whether it's individuals who are afraid of receiving a diagnosis, families who don't know how to deal with the diagnosis, or sometimes providers, medical providers who feel as though their patient base is going to be so worried, upset, and stigmatized by a diagnosis. But so many of these things come back to the dollars involved. Do individuals, even when they get an early diagnosis, a diagnosis at any point in the disease progression, do those dollar signs just send their blood pressure soaring? And so how can we, in early intervention, come up with something that tells people, hey, you know what? You're not going to have to turn around and put mom has mild onset. She has a mild case. There are ways that you as a family, that she as an individual can begin to deal with things, that I as her healthcare provider will help her navigate this process, and that it is a process. It's not a matter of a month or two down the line you have to institutionalize mom, because she's not at that point in her disease progress. So I think it snowballs for people. Just like when you get a cancer diagnosis, people snowball that response. And I think part of our early intervention focus needs to be destigmatizing, certainly, and along with that, making the public, as well as the medical industry, etc., aware of progress, aware of the differences in the level, the stage of diagnosis, and how those individuals then will be moving through those stages. And everything is not all at once. Everything is not catastrophic financial failure all at once. which I think a lot of people turn around and are stymied by immediately. I don't want to know. I don't want to watch because I don't have the money to deal with this disease.
Thanks, Diane.
Sure.
Tina, and then Pam, and then we'll go to Joe. Tina.
Hi, I would like to see more of routine. I would love to see this in place. Routine support groups offered between assisted living and nursing facilities for families involving loved ones at times, just to assist with getting a better understanding of communication styles and different approaches. I'd also like to see a routine support group offered from the assisted living and nursing facilities offered to the community as well. I just think that a lot of family members will feel more comfortable going into a facility that they're comfortable in rather than going to a random support group, and just feel like that's more of a successful kind of approach. But I do think the more education that we have through, I know it's long-term and it's not early detection, but I think a better understanding can lead to early detection and more education through just actually coming in and interacting and getting the information that they need to get a better understanding, basically.
Thank you, Tina. Pam, and then we'll go to Joe and Leanne. Pam.
Yes, thank you. So in regards to brain health activities, I'm drawn to Dr. Paul Raya's philosophy on habilitative care out of the Massachusetts, New Hampshire Alzheimer's chapter, where he supports and promotes the habilitation of those with Alzheimer's, and that you focus on their functional capabilities versus what has been lost. And there is a huge focus on the emotional, psychological capabilities of the individuals with Alzheimer's and dementia. And this program, being very long and varied and to describe, just basically, it focuses on the individual's ability to feel. And we all know that in spite of losing declarative memory, those with Alzheimer's and dementia still have the ability to feel and to have emotions. And the more positive that we can make those, the better their life is. It also has been proven to decrease the progression of dementia. These programs are fabulous for caregivers, institutionalized caregivers, but also caregivers at home, whereas you're creating a positive space for that individual on a day-to-day basis, and helps decrease confusion and all those thoughts that the individual's having that they don't understand. The second part of this is about the education to the community and considering education in high school for parents of high schoolers, even elementary children. These parents are facing early diagnosis with their parents, maybe their grandparents, and educating them through those systems may not be a bad idea. Also, there's not a bad idea in educating children to the issues that is happening with grandma. And it can be done in a very positive way. And lastly, I don't want to forget independent living and retirement communities. So many people living in those spaces are afflicted with early Alzheimer's or a spouse that is in mid-stage or approaching end stage. And there's definitely a forum there that can be tapped into with the managers of those centers or of those apartment complexes that can help with that early diagnosis, with intervention, with resources and flyers and so forth that can be distributed. And that's it. Thank you.
Thank you, Pam. Joe, and then Leanne.
Yeah, so I think that these comments have been absolutely spectacular, and I absolutely love the amount of diversity in the comments. When I think about early intervention, I think really about two separate things. The first thing is I definitely think we need to do more to publicize and broaden public awareness. Some of the comments have referred to different sectors of the community where people are interacting with people from the general public. How do we get to each of those sectors? Well, I think a much more broader public campaign where we're telling people, hey, here are the primary signs and symptoms. If you see people like this, make someone aware, or and also to get and advocate for testing. I think those are great things. And I think such a thing could be potentially funded through some sort of public-private partnership where we're bringing everyone from the community together to sort of put that out there. Similar to what we do with cancer, we have the pink ribbons, and then testing awareness with specific forms of cancer is also good. And then the other thing is I really think it's important that we have more options for people in the community that are self-serving options, like memory cafes and like some of these other things. I think it's really important that we bring families and individuals together, because we all know that the disease process is different for everyone. And what might sound strange to one person, once they start talking to families, they figure out, hey, this is completely normal within the certain scope of a disease process. But bringing people together, giving them options where they're not putting them necessarily into a program, but maybe they just want to go once a month, or maybe they just want to go, and interact and network with other families. I think those are really important too. So those are the two thoughts that I had, and I appreciate the time.
Thanks, Joe. Leanne.
Well, again, all great comments. I just agree with everything that everyone's talked about. I think one of the things that stands out to me is not only in the early intervention, but in in all stages of the disease process, there are a lot of people who are caregivers who are still working. And so many services and things that are out there may happen during work hours or trying to get to the doctor. They simply they can't. They have a caregiver staying maybe with their loved one, or they are with their loved one, or they have to go to work and they don't know what to do. So I think it's just arming people with information and giving them the resources. It's been mentioned many, many times through all the previous comments, but those, again, were my notes, were just public service announcements, whether that's billboards, radio, direct mail, social media, just what is out there, and that there is help available, because there are some great organizations, many of them in your slides, many of that, so much of that information already is there, but again, connecting the dots and getting people to know where to go with that. And then the other thing is the possibility of some type of clinic, if you will. I'm at a loss for a little bit of a better word for that, but somewhere where they can just stop in to get some help, or bring their loved one with them and have someone supervise those that are struggling with Alzheimer's and dementia, while the caregiver or the family member can learn and get some help, because a lot of times they don't have anyone to stay with their loved one, so they can go do these types of things after hours or during a normal work day. So those are just kind of some of my more the kind of public service arena to help during early intervention.
Thank you. I'm going to do a quick check-in. I think there are some folks who had to leave early. The folks we have not heard from so far are Director Ashenhurst, Vice Chair Diefenheimer, Representative House, and Director McElroy. Are any of you back with us? Okay. Did I miss anyone else who is still here and didn't have an opportunity to contribute? And would anybody like to add any final commentary before I hand it off to Yanda to talk a little bit about data and findings? Okay, Yanda, I think the floor is yours.
And I will hold it only briefly. I so appreciate the fact that we are moving
well along and having some great comments. One of the things that is really striking me about the conversation on this topic today is the number of times people are pointing at existing resources or existing information, less so than, I mean, certainly we're talking about needs as well, but there have been a lot of comments today about what is out there. Some of the community initiatives, the Memory Cafe, the Lake Health Study are examples of what I could give you. We certainly, did, like we did last week, a review of the types of publicly available information that is out there on these topics, and shared a portion of that with you. Some of it absolutely corroborates some of today's conversation, but I actually feel like today's conversation is going beyond the data that we have so far. And so we're definitely going to have to mine the chat, because I am seeing resources come up. But if you know of information, so for instance, like for example, for memory cafes, there may very well be a recommendation come out of this task force about the Massachusetts model and how it can be replicated and scaled up in Ohio. But there actually is existing work being done in Ohio around memory cafes. I don't have data about that. So it would be great to get my hands on some information about the number of them that exist in Ohio. Where are they? Any successes or outcomes that they've had, because, it's important to note that our findings are not going to just be needs. There is a message of hope that will be part of the narrative associated with this. And some of that hope is built on, look at some of these building blocks that are in place. And we want to be able to discuss them. So I will just kind of put a pause in that, and I'm seeing some things pop out again in the chat, so we will continue to try to catch that. And I will turn it back over to Leanne, because I think we are probably ready to move on to our next topic.
Thanks, Yanda. There are some things showing up in the chat. Let me just ask if there's any additional information that anybody wants to add outside of the chat before we move on to our next topic, which is the healthcare bucket. Okay, all right, I'm going to start sharing again, and just a moment to get all of you back on my screen here. There we go. And can you see the healthcare slide? Okay, so these are the subtopics that we have pulled together into the very, very broad healthcare bucket. And for folks who can't see the slide, I'll read through those quickly. Policies and strategies that improve the healthcare individuals who are diagnosed with Alzheimer's and other dementias receive. Policies and strategies that improve the quality of the healthcare system that is serving people diagnosed with Alzheimer's disease and other dementias. Policies and strategies that evaluate the capacity of the healthcare system in being able to meet the growing numbers and needs of people who are diagnosed. Policies and strategies that equip healthcare professionals and others to better care for individuals who are living with Alzheimer's disease and other dementias. I believe C7 should say policies, not police. A typo there, I apologize. Policies and strategies that increase the number of healthcare professionals necessary to treat the growing populations of people who are getting older and living with Alzheimer's disease and other dementias. And policies and strategies that increase and improve research on Alzheimer's disease and other dementias. And I will tell you that I took a little bit of license to use some best practices language. So I just added some things around aging Ohioans. I forget what the language in the Senate bill was, but sort of changed that language just a little bit to be a little more respectful, and included the language of people living with And also, I think in one of the buckets, we changed the language to people impacted by, as requested last week. All right, so those are our topics for the questions around healthcare. And I'm looking at my time. It's just 11:10, which is exactly when we said we would start. So I'm going to make it fairly easy on myself this time, and I'm actually going to use the alphabetical list. So you'll know generally who's coming next. Let me just check again and see if Director Ashtonhurst or Director McElroy have been able to join us. Okay, so I am going to start with Trey, and then I'll go to Doug and Jen Blau. Trey.
Yes, so I'll be brief. I think one area to look at, which, you know, we've seen some cost savings in certain states, is around care coordination, especially through state Medicaid, program. But there's definitely opportunity around that. Better care coordination overall sometimes increases the likelihood of the patient as well as the family just to have a more successful result. The other thing that I would like to mention as well is really looking at one of the things that we've seen is how do we scale, grow, really equipping the healthcare professionals with training. I know this has come up a number of times, but I think the reverse of that is the expectation from facilities to conduct that training and coordinating that training would likely need a higher reimbursement to compensate for the training, as well as to compensate the staff post-training. So I think we have to look at it through a holistic perspective and not be narrow in scope. If we expect, you know, a higher level of training for staffing, which should happen, we have to ensure that that's paid for to hopefully produce better outcomes long term. So beyond that, I mean, I would just go back to, you know, looking at the whole entirety of the health system and healthcare system in the state and looking at where we can create synergies overall that produce better outcomes.
Thanks, Trey. We'll go to Doug and then Jennifer and Sally.
Yeah, I just want us to be a little more optimistic in this space. Back in the late 90s, I worked for David Hobson, Congressman David Hobson, who wrote the AIDS bill for the state of Ohio. And every year, a number of folks in various stages of age would come down to the Capitol in DC for the quilt ceremony. And in less than 10 years after I was there, they certainly don't have a cure for AIDS, but they do have something that'll keep people alive for a long period of time. Talking to Dr. Boutros, who's head of Metro, I guess we're looking at some really promising research in the Alzheimer's space right now. So it's my hope that whatever we do, we continue to talk about the positives on the research side and then see if we can get more funding for some of those promising drugs or treatments.
Thank you, Doug. Jen Blau.
Sorry about that. You know, I really respect the last couple of points that have been made. As a human resource director myself and looking at staffing for an organization, the ability to find people that you know can check the box, if you will, on a certain skill, or the ability to find appropriate training for that skill for existing employees is you know can be pretty daunting, and it's very critical. The other point that I wanted to touch on is the compensation for healthcare workers, especially those that are more on the front line of working with people living with dementia. You know, I have a horrific story from when my dad was ill. He did not have dementia, but he did have a brain tumor, and it greatly impacted his ability to do any kind of daily activity. So we had made the decision to put my dad into a skilled nursing facility, so that in large part from my mom's health, because she was taking care of him when he was home. But when he was in, frankly, a very expensive skilled nursing facility, and this was in Illinois, not here in Ohio. When the aides went to move my dad, apparently they either weren't familiar with the equipment to move him or with the specific instructions, and they ended up dropping my dad. And he was, as you could imagine, horrified and terrified. It took him a while to be able to communicate that to us so that we could then follow up on it. But when I, as an HR professional, looking at compensation structures for the jobs that I hire for, and I think about the kind of care that I would want for my loved one, my husband, an $8 or $10 an hour job doesn't cut it. Doesn't cut it for the kind of skill and care that I would be expecting. So I think that as part of the prioritization that Senator Wilson talked about earlier, I think that we need to really consider where compensation for these healthcare workers fits in the overall recommendation. And that's it for me.
Did we lose Leanne's audio?
I was just about to say,
I'm
Leanne.
sorry. I'm sorry. I'm doing the same thing. I'm saying to Sally, it looks like you're on mute. Thanks. I'm sorry. It looks like Sally's line is muted. She might be on another call. So I'm going to go ahead and move us on to Lisa, and then Catherine, I'll loop back to Sally. So Lisa and Catherine.
Hi. Yeah, this is a sort of giant bucket, I guess, as we all know. And I can't help but think back to some of the other comments that have been made as to, the recommendations that we're going to make based on the findings that we have, and really what policies and strategies are in place for people living with this disease. Right now, just to talk sort of in my own realm, the nursing level of care definitely has more regulation in place for them than the assisted living level of care, which the assisted living level of care tends to be then where a lot of the memory care focus has been pushed, right? Because lots of folks living with any of these diseases may not necessarily have acute nursing needs, although they do require a heightened level of care. And so the question then sort of becomes, how do we assure that everyone who is providing those more end stages or moderate to end stages level of care are being held to some standards around taking care of people with these diagnoses. So I think we have an opportunity to consider some focus on that piece in an effort then to say, if someone is able to say they are memory care, then that means they have, they have the additional training necessary for people living with these diagnoses. So thinking through that aspect, I think, will be helpful as well.
Thanks, Lisa. Sally, let me just check and see if you're back with us. Okay. Catherine and then Bonnie.
So this comment is going to be broader than our discussion today, and it's focused on long-term care, but I believe the outcome of what we're trying to accomplish may be helpful, and that is we're working with Kent State University right now to develop a survey for nurses across the state. And that survey is to learn why or why not they have chosen long-term care. Why did they not move into long-term care when they left nursing school, or why did they? Or even post-nursing, at what point did they make a career change either back to acute or into long-term care? And our hope is that with this survey, we're going to have an understanding of perhaps some changes that could be recommended in nursing programs. But one of the things that we've learned, even in the preliminary stages, is that the compensation level right now in our nursing schools around the state is such that it's really hard to attract nurses away from more highly compensated work on the floor and in the facility and in the institution. So we have a tremendous petition for a few number of slots and need more nursing instructors. We need to have the ability to have more nurses willing to move into the academia field in order to provide training. So that compensation, whether it could be state supported, would be extremely helpful. And then, of course, we need to make sure, we believe that what's going to emerge from the study that we're doing is that the training for long-term care and therefore dementia would be incorporated in that needs to be a more robust part of the nursing school curriculum. But more to come on that. I guess the key takeaway for me with my comments just now is that compensation in the nursing schools in order to gain and attract instructors is really critical.
Thanks, Catherine. We'll go to Bonnie and then to Greg.
Thank you so much. My three comments really are about potentially changing the frame of how we think about healthcare and dementia. First, we send such a clear message to people who are living with dementia that there is no treatment. There isn't much they can do. And part of the reason we do that is because we're seeing treatment as, or I'm sure I'm not using the right word here, as so medical, when we know that there are so many things that we can be doing to enhance somebody's life, but they are outside of the traditional healthcare system. And so somehow we need to bridge that gap so that the healthcare providers are sending a message that includes the rest of the community. We have a wonderful colleague at Benjamin Rose that would say, if X, Y, and Z were a pill, we'd all be using it. And I think that that's a really important comment moving forward. Secondly, when we talk about healthcare and people with dementia, and I'm just so glad to see that we have changed our frame to people impacted by dementia, we do need to think about the other part of the care dyad and the person who is caring or the family that is caring for the person who is living with dementia, since their health status changes so dramatically. And my third and last comment is that we are talking about the present and a little bit about the past right now, but the future of healthcare and people with dementia is going to include quite a bit of technology, and that's technology in the home. And we haven't really addressed that at all. So thank you so much.
Thank you, Bonnie. I'm going to go to Greg, and then Dr. Drost, and then Tina. Greg?
Sure. Thank you. I guess I would just hit on again the financial side of things, and there's just such a big gap between low-income families and the type of care that they receive in dementia environments. So, putting policy towards that, it really helps make that more robust and more equal to what somebody would receive in a private pay environment. I guess it doesn't have to be equal to, but at least needs to be fair. And I don't know if you've spent any time in any of those environments. They can be pretty tough. And then also, just leaning on the training for medical professionals, standardization, equipping them with the right type of tools to help support, diagnose people with the disease, with dementia, and then increased training and standardization for care communities like ours across the board. And right now there's such a wide gap between the level of training between assisted livings and skilled nursing that I think there needs to be an increased level and standardization there as to how the training needs to be implemented. And then what the follow-up is to make sure that the care team is being trained properly. That's it.
Thanks, Greg. Dr. Drost, are you still with us? Yep, there you are.
Yeah.
Hi.
So piggybacking, I think right off of what Greg was saying, I think that there are quite a lot of needs in the state of Ohio from a healthcare standpoint. I mean, if you're thinking about providers and not just physician providers, though there certainly are a shortage of geriatricians across the country, but certainly in Ohio with less than around 50% of fellowship slots that are filling. There's also a lack of, a shortage of neurologists, particularly neurologists who are trained, skilled, interested, perhaps in really digging in and caring for dementia in that comprehensive sense, much more than just looking at what medications are available. Neuropsychiatrists who specialize in dementia evaluations, cognitive evaluations are also shortage, and they're looking at psychiatry, geropsych, if you have on the doctor medicine hat, but that really does flow through, I think, through the entire health system, whether you're looking at nurse practitioners and physician's assistants, you're looking at PT, OT, speech therapy, training and really harnessing or trying to encourage people to not only have a baseline education, which we certainly need across the board, but also those who specialize in the care. So a physical therapist who is specialized in working with an older adult who is living with dementia and their caregivers to work through or occupational therapist, how do we work through a challenging behavior around bathing, for example? I think that's key, and that's across the board. In healthcare as both the education, but we can't just focus on people who are up and coming. We really have to start focusing on people who are currently practicing either earlier in their career, it's mid-career or late career, and ensuring that there are some universal education requirements for everybody within the healthcare field and licensing requirements in the state of Ohio. I think that there are six medical schools, I think, in Ohio. Maybe there's 7 at this point with some branches around. But there used to be quite a collaborative between the offices of geriatrics, which are actually supported by the state as well, across the public institutions at least. And maybe thinking about how do we reinvigorate that collaboration between medical schools so that we are, at least within the state of Ohio, making sure that we are providing a baseline education, but probably also advocating for increased time and education around diagnosis, treatment, evaluation, support for Alzheimer's disease and dementias.
Thank you. We're going to go to Tina and then Rhonda and Ombudsman Lawbert. Tina. Tina, are you still with us? Okay, I'm going to go to Rhonda, and then Rhonda may not have joined us today. Let me just check. Rhonda Johnson? I think Rhonda was not able to join us. Okay, I'm going to go to Ombudsman Lawbert.
There are lots of things here on this slide, so my thoughts are kind of all over the place.
It's a big bucket.
Yeah, it really is. So I just want to mention, because I'm not sure where it might fit elsewhere, or maybe it fits here, is, we really need to tackle the issue of ageism. I think the fear and lack of understanding about dementia contributes to ageism. So I think that's important as we're educating professionals and so on, to note. There is a clinic. I've been trying to look up the name of it, but I'm not finding it right now. There's an oncologist at OSU Hospital, and for people with cancer, she has a clinic specifically for older adults with cancer. So when they come in to see their oncologist, they're seeing, I think it's like 5 different disciplines that day. They're seeing a social worker, they're seeing a dietitian, they're seeing other professionals. And that might be something that we want to think about with regard to dementia, that when someone does go to the doctor for dementia, that they're seeing all of the support system, every kind of professional that could be helpful to them. So that's one. And then, when I think of healthcare, I think more of primary care, but I know other people have talked some about long-term care, so I'll go there as well. I think somebody mentioned pay for caregivers, and certainly I believe that that's true. And one of the things that we need to do is professionalize or provide greater respect to people who are providing direct services. And, we've had this weird title called STNA, State Tested Nursing Assistant in Ohio, since the requirements for nurse aid training. And other states use CNA, Certified Nursing Assistant. Why on earth can't Ohio do that? I think just calling them certified, thank you, Pete, calling them certified, and the things that go along with that help with respect of the work that they do. So I recommend that. With regard to research, several years ago, we asked the Department of Higher Education to give us an inventory of aging-related research. And they were able to do that very easily. So I think that might be something we could do also, is ask the Department of Higher Education to send something out to all of the universities and ask for what is their current research in the area of dementia. I think you would be surprised at how much is actually going on. I think there's more going on than you might imagine, in a variety of ways, and including things like communication, how to communicate effectively with someone from a healthcare standpoint, from a healthcare provider, with someone with dementia, and so on. And then the last is, there was a comment about assisted living and memory care. We really need some memory care standards. During the pandemic, we would talk with residential care facilities, and the facilities would say, well, that person's in assisted living, we're having a problem in memory care. Well, it's all one license. So just because the facility for marketing purposes says they're a memory care provider is the same license as the residential care facility down the street that might not use memory care in their name or, as their promoting themselves. So, but we really need some standards. I mentioned this last time that if there is a unit or if a provider is saying that they provide memory care, we need to know what that is, and consumers need to be educated about what is special about what they're getting there.
Thank you. All right, Diane, and then Pam and Joe. Can I go to Diane?
I hate to say it, but I really have nothing new to add. So I'm going to yield my time back because I think so many people have put so many points eloquently here. Thank you.
Thanks, Diane. Pam, and then Joe, and then we'll go to, oh, Leanne had to hop off. So Pam and Joe, and then we'll go to Lori. Pam? Oh, did we need to lose Pam? Pam, it looks like on my end, you're on mute.
So sorry. Do you hear me now?
Yes, thank you.
Okay, I apologize. So the strategies coming to my mind are, first, encouraging the family involvement with the care or the care planning of those in memory care, AL, skilled nursing. Even though those settings offer support for families.
Pam, we lost your.
Might be written is not always implemented. The next thing is increasing the capabilities of respite care. And I see that as a huge need for the family caregivers at home, whether it's a 1 day or a week. And right now, hospice will reimburse for some respite stay. However, most other respite stays are truly private pay, and they're not cost effective for the family at home. So maybe considering some reimbursement for that in some way would be very helpful. And then the promoting of some of the online Alzheimer dementia screenings, for example, the Ohio State SAGE testing might not be a bad thing to look at, just to give families at home a place to go, or even those in early stage Alzheimer's. Although I guess there would have to be a huge explanation to that because, cognitive impairment or having a memory moment of not remembering doesn't always signify that you're into an Alzheimer's type of diagnosis. So there has to be some considerations with that. And then lastly, Beverly was speaking of the STNA versus the CNA. I totally agree. Why don't we just call them certified nursing assistants? But also in their 75 hours of training to be a certified nursing assistant, although they do have some dementia Alzheimer's training in that, perhaps there should be a higher focus, because chances are that 75% of the patients that they take care of outside of their training are going to be diagnosed with dementia and Alzheimer's. And then as Catherine was talking about KSU with the survey for the nurses, I just know as being a nurse, executive hiring nurses for long-term care, they know very, very little once they come into those spaces. There's not a lot of focus about skilled nursing care, memory care in the nursing schools. And so if there was some way we could incorporate some better education to that, those nurses might elect to go into those settings. And if it could be done in more of a positive way, that would also be great. So that's it. Thank you.
Thank you, Pam. Thanks so much. I'm going to go to Joe and then Lori and Jean. Joe?
Thank you. My comments are around two separate areas. First is to echo what Trey said around care coordination. I think that's so unbelievably important when we're talking about the complex needs of this community. A lot of times what we see as home care companies are the providers are left out of that conversation. It's either being done by the payer or being done by the government. and they're not in regular contact quite often with that patient or that family, whereas the in-home caregivers are. So if there's an opportunity to include the in-home providers in the care coordination conversation, we can significantly improve the outcomes of this population. The second piece is around training, which I've talked about before. It's our belief that we need to do two things with training. The first is to create a sort of a standard set of recommendations for home care and in-home providers on dementia-related training, but not necessarily mandate that. And instead offer the opportunity for agencies to become specialized in that by creating a more stringent set of expectations for those providers. And so the difference is if I'm a company that wants to say I'm specialized in this area, I can do that as long as I'm meeting these level of expectations. And I think we talked about paying for these services. I think one opportunity that we have is if you're certified as a specialist in this area, and potentially if you're participating in care coordination, there's some sort of rate add-on for both of those features. I think if we were offered an incentive to agencies rather than just give it to everyone, you're going to see there's a lot of agencies are going to be willing to step up to the plate and really improve quality. So those are the two things I wanted to mention. Thank you.
Thank you, Joe. You go to Lori and then Jean.
Thank you. In looking at C4, when we talk about improving the quality of healthcare systems and their ability to provide the better care for people with Alzheimer's disease, I think about transition of care as being an important focus, that oftentimes when people transition from one level of care, whether it's coming in through the emergency room, heading to the floors, or then upon discharge into a post-acute care facilities, information is often lost. This is where we tend to see a lot of people becoming very vulnerable. And I think when Jennifer talked about better training in a more integrated way with our interdisciplinary teams, I think that could be part of the recommendation to meet the need of looking at the struggles that we have with transition of care. Thank you.
Thanks, Lori. Jean, and then we'll go to Pete.
Thank you, Leanne. Well, I have about 4 points, I think. First, I don't want us to lose sight when we say the numbers of people in the healthcare system, that we're not just looking at what you might call higher level health professionals. There's a huge and vast shortage and problem with just direct care, but I don't want to not call them professionals, but direct care professionals. We've got to do something about that, or create a strategy that increases that number, whatever that strategy would be. I did want to talk a little bit. There actually, and I did share all this information in the past with the capacity committee, so I'm assuming you had access to it. I did share there is actually a 15-point piece of rules in assisted living of how, if you serve anybody, regardless of whether you call it memory care or not memory care, of how that service to them is special. And if that's not happening, well, that's a regulatory issue, because that is a regulatory requirement. I do think with training, one thing we have to be cognizant of, especially during this incredible workforce shortage, that we make it in kind of more of mentoring training, of kind of learning actually in the doing. I do hear providers say, we had people show up and they stayed for training and orientation and then they left. So the training and orientation we did nothing, because as soon as they were actually to be working, they left. So I think that's something that should be kept. I do agree with the comments Trey, some others made, that if we have an increased focus on training, then we need to, but everyone keeps using the term, we need to increase rate or reimbursement. One of the big problems in assisted living is that's most of it is paid for privately. So we have to also take into account some of Greg's earlier comments that, families are often, hesitant about that. And currently about 40,000 people are served in assisted living now in Ohio. I do think if you're truly at a Medicaid level, we need to definitely increase that reimbursement to make it more available to people who don't have the funds to privately pay. And then lastly, I would say that I agree completely with comments, and this came out of our capacity committee loud and clear, that we need to make not just more information available about potential short-term respites, but actually some reimbursement for that if we're really going to help families and this huge cadre of people we have who are providing care without being paid for, without being paid. And we need that, or it will, as Senator Wilson said, eat up our whole budget. Thank you.
Thank you, Jean. All right, we are heading down the home stretch here. We have Pete and then Senator Wilson, and we'll loop back to Sally. Pete.
Okay, I'll try to make this quick, given that we are in the home stretch. I think that the comments made about, in one way or another, workforce shortage by different people are super important, and that, you know, as we're looking at findings from this task force, that the existence of the workforce shortage, which is, as Jean said, you know, really particularly pronounced among, whether we want to call them CNAs, STNAs, or whatever other term you use in different settings for these individuals who are providing direct care, along with professionals. You know, that's a huge issue, and one that really needs attention from a lot of perspectives. And compensation for them is at the top of the list, because anyone would tell you that is trying to recruit that the inability to compete, or the challenges in competing with all the other possible places where these individuals could be employed is extremely challenging. So that's one piece, and we just really can't overemphasize that one. There was a mention about technology. I think it might have been Bonnie that brought this up, and I just wanted to share that on Friday I was a member of another group. I was actually filling in on another group in the DD area, and DD has something called Technology First, which the idea of that is, when you're looking at services for an individual, looking at technology first. And part of the problem is it's not really being implemented that well, but it is a goal that the state of Ohio established for people with developmental disabilities. We are a quote unquote technology first state, just like we're an employment first state. So that is something that I don't think, again, looking at the workforce shortage, and this is a potential way of helping with that, is by making better use of technologies and really finding out what is out there, making that available to, or information about it available to AAAs or others who are, and to families, people who are planning care, that might help with the workforce shortage as well.
Thanks, Pete. Senator Wilson, and then we'll go to Sally. Senator Wilson.
Thank you, and apologize for constantly talking about money, but I'm going to be the one of to get to fight this epidemic that we have coming in Alzheimer's and other dementias. I talked earlier about the whole idea of prioritization, which I continue to think is important. Now I'm going to talk about another subject, and that is that I know many of you in residential care, whether it's assisted living or in nursing care or whatever, you lose money on your reimbursement for those that come through Medicaid. And you've always been able to stay alive, keep your head above water because of private pay. The problem is that people are getting smarter. Somebody said earlier that people don't put their loved ones in because they don't want to have mom's money or dad's money all used up and not come to them. The other thing that happens that I think we ought to put a priority on looking into, what are the rules surrounding when a person can claim that mom has lots of money. And so that we don't continue to diminish the private pay sector and continue to have a leak in our boat as we pour money in the top. So I would suggest that that would be a priority of something we should look at.
Thank you, Senator. And Sally.
I'm sorry, I had to step away for a little bit, so I apologize if I'm redundant. I know that we spent a lot of time in the capacity committee, talking about this. So it might be that there's a number of, I know that a number of committee members gave some resources and data. I think some things that might be helpful to take a look at. I know we spent a lot of time talking about, it almost feels with some of this, it's if we don't address the workforce issue in some of these areas, it's almost like a house of cards that will probably fall. And so continuing to look at and examine the workforce issue, not only for people who are in the field to retain them. COVID has really burned a lot of people out, but also bringing new people into the field as well. And I know some individuals had talked earlier about looking at education, not only for physicians and nurses, for our direct care staff and some of the allied professions, social work, therapies, and such. And I think we're fortunate in that Chancellor Gardner was in the House and the Senate for many, many years prior to going to higher ed, and I think has a good and thorough understanding of aging issues and dementia issues. So he may be someone that has an ear towards if we want to look at making some changes in the educational field. I think I was just at a senior center opening about a week ago, and he was one of the featured speakers, and very happy to see this new senior center in his hometown reopening. So I think that may be a nice ally for us. And I know Bev had mentioned earlier, just really putting together a definition of what a memory care unit I do think is really important. And there's lots of places that we can go to borrow upon that. So I apologize if I was redundant. I did need to step out for a little bit. So.
I've lost your sound, Leanne, if you're talking.
Oh, I did it again. I'm trying to be so cautious, and I did it again. Thank you. I was just checking to see if Director Ashenhurst or Vice Chair Diefenheimer had been able to join us again.
Yeah, this is Jolene Diefenheimer. I just wanted to add real quickly to, all the comments were excellent. The one part when we looked at the strategy C11 surrounding increasing and improving research, one of the aspects too that I want to make sure that we remember is that translation. So making sure that that research and best practices are actually translated into the field and adopted. So how we can create that system to make sure that all that great work is then being implemented through Ohio.
Thank you. And I know Director McElroy is on the chat. I wasn't sure if she was still in the group. Director McElroy, are you still here? Would you like to add any final comments? Okay, I'm going to stop sharing. Thank you all. Everybody take a big deep breath. Once again, you did it. I am utterly impressed at how much we were actually able to get through today. I really thought we would not get through much of the healthcare conversation at all. Yanda, I'm going to hand it off to you to wrap us up here as we close out.
So, hey, I'm not muted. Thank you, everybody, for a great conversation. I can't even begin to, I have used all but 10 pages on a brand new tablet, taking notes by hand today. So that's a lot to kind of wade through. But it's very good information, and I'm so pleased with how you all have gotten on board and joined us in working through things this way. So just the only other thing I wanted to leave you with before turning it over to Alex for adjournment are a couple of housekeeping issues. Item number one is after doing the doodle poll for next week's meeting, we are going ahead and leaving that meeting as scheduled. We have a large majority of the group that is available to participate, so we will be tackling our next topic at that meeting, as well as hopefully sharing some findings with you. But along those lines, we have put a fourth meeting on the schedule for July 12th. And the report, the draft report, will be due to ODA later that week or the early part of the following week. And so what we've done is we've put that meeting on the schedule so that we have an opportunity to work with you all on the findings piece, where we are with draft findings, what we anticipate will be going into the report, and have one last opportunity to go through that with you all, and let you know kind of how that is shaping up. Now, we are putting it on the calendar, I believe, as a 3-hour meeting, but we're hoping that we'll be able to do this in a 2-hour meeting. But we thought we'd rather ask for the time and not need it than not ask for the time and end up needing it. So, if you will bear with us on that, then there will be a little bit of a break in the meeting schedule while we finalize the report and work with ODA on that. And then we will be coming back to you with a new process for moving into the next phase of this project. So just stay tuned. We so appreciate your fluidity on this, as well as your continuing commitment and enthusiasm. So I will turn it over to Alex so he can adjourn the meeting. Again, thank you so much for a good conversation. I really see how this is starting to shape up. So thank you.
Yolanda?
Yes.
This is Jill Earl, and I wanted to let you know that it looks like on the calendar for July 12th, it looks like the meeting is scheduled for only 2 hours.
Okay. All right. We've gone back and forth with Tessie. I've forgotten where we landed. So, okay, it's 2 hours.
Yeah, we have it for 2 hours. Let me know if it needs to be adjusted.
Okay.
Okay. I think we'll know. This is Leanne. I think we'll actually know more at the end of next week. We'll sort of see where we are. Given how well today went, I was laughing a little bit, Yolanda, when you said 2 hours. I thought no pressure there. But given how well today went and how much we were able to accomplish, hopefully we can do that.
All right. I don't know. Is Alex still with us, or Tessie? Do you need to wrap this up?
I think we're okay. We just need a motion to adjourn and then a second to do so. And then I think we can conclude if you're ready.
Okay, we are.
This is Catherine Broad. I'll make a motion to adjourn.
Thank you, Catherine. And a second by Pete. Thank you so much, everybody, for attending today. And I'll be sure to send out meeting reminders and additional links as we move forward.
All right. Thanks, everybody.
Thanks everyone. Bye-bye.
Bye.